Okay, today we're going to talk about inflammatory heart disease. The first one we're going to talk about is ineffective endocarditis. Now, with a cardiac defect, blood may flow rapidly from a high pressure area to a low pressure area, eroding a section of the endocardium. Now, platelets and fibrin adhere to this endocardium, forming a vegetative lesion. Now, during bacteremia, bacteria become trapped in the low pressure sinkhole and are deposited in the vegetation. Now, additional platelets and fibrin are deposited, which causes a vegetative lesion to grow, and then the endocardium and the valve are destroyed. Now, valvular insufficiency can result when the lesion interferes with normal alignment of the valve, and if the vegetation becomes so large that blood flow through the valve is obstructed, the valve will appear stenotic and then is likely to embolize. Now, ineffective carditis, previously called bacterial endocarditis, is a microbial infection, usually caused by a virus, bacteria, or fungi of the endocardium. Now, the most common organism is strep V, or Streptococcus viridans, or strep A. Now, ineffective endocarditis occurs primarily in patients who abuse IV drugs. It also can occur in patients that have had valve replacements or have experienced some type of systemic infection or structural cardiac defects. Now, possible ports of entry for this are going to be the oral cavity, especially if there any kind of dental procedures have been performed. So any kind of skin rashes, lesions, or abscesses, any kind of infection. So it could be cutaneous, GI, systemic, or surgery or any kind of invasive procedures, especially those that have had some type of line placement, central line placement. Now, your clinical manifestations are going to be fever associated with chills, night sweats, malaise, and fatigue. You're going to see anorexia and weight loss with these patients. You're also going to hear a cardiac murmur. Now, this is usually newly developed, or if there's an existing one, it'll have a change in its pitch. Now, these patients will also develop heart failure. They'll have evidence of some type of systemic embolization. They will also show petechiae, have splinter hemorrhages, and they'll show Osler's nodes. These are on the palms of the hands and feet, and you can look that up to see what those are. And Janeway lesions, which are flat, reddened macule on the hands and feet. These patients will also have positive blood cultures. Now, the diagnosis, the most reliable criteria, is going to be those positive blood cultures. Also, a new regurgent murmur can be heard, and that's one of the diagnoses. And also any kind of evidence of endocardial involvement through an echocardiogram or a TEE. Now, complications, there's three major complications you're going to see with this. The most common one is heart failure. You're also going to see arterial embolization, and this happens in about half the patients that have this. And then also splenic infarction, so infarction of the spleen. And this is going to occur with sudden abdominal pain and with pain radiating to the left shoulder. Now, interventions, you're going to take care of these patients usually with antimicrobials. You're going to have rest balanced with activity and do supportive therapy for heart failure. Now, if these interventions are successful, surgery is usually not required, but the cardiac surgeon may be consulted if the antibiotic therapy is ineffective in sterilizing the valve, or if there's refractory heart failure develops secondary to a defective valve, or if the valve, large valvular vegetations are present, or also if there's any kind of multiple embolytic events. Now, current surgical interventions for ineffective endocarditis include removing the infected valve, and replacing it with usually a biologic or prosthetic. It also could be repairing or removing congenital shunts, or repairing injured valves in chordae tendineae, and also drainage of abscesses of the heart. Now, nursing care is going to be the same as patients with valve problems, and we'll go into that in another video. The next thing we're going to talk about is pericarditis. Now, there's two different types. There's acute and chronic constructive. Now, acute is the inflammation or alteration of the pericardium. That's the membrane that encloses the heart. Now, the problem may be fibrous, serous, hemorrhagic, purulent, or neoplastic. With chronic constructive, this occurs when the chronic pericardial inflammation causes a fibrous thickening of the pericardium. This is usually caused by tuberculosis, radiation therapy, trauma, renal failure, or metastatic cancer. Now, in chronic constructive pericarditis, the pericardium becomes rigid, preventing adequate filling of the ventricles, and usually results in cardiac failure. Now, the etiology, acute pericarditis, is most commonly associated with ineffective organisms such as bacteria, viruses, or fungi, and this is usually a respiratory problem to begin with. Now, it also can be caused by post-myocardial infarction syndrome or Dessler syndrome, also by post-pericardotomy syndrome. And another thing, it could be acute exacerbations of systemic connective tissue disease. So any of those things can be a cause of this. Your clinical manifestations with acute, you're going to see substernal precordial pain that radiates the left side of the neck, the shoulder, and the back. And this pain is usually grating and oppressive, and it's aggravated by inspirational breathing. Also by coughing or swallowing. Now, the pain's worse when the patient is in the supine position, and it could be relieved by sitting the patient up and leaning them forward. So you're going to ask specific questions to evaluate chest discomfort to differentiate the pain associated with an acute MI. So you want to make sure that they're not having an MI also. Differentiate it. You also will probably hear a pericardial friction rub, and this will be positioned at the lower left sternal border. Now, with chronic constructive pericarditis, they're going to have signs of right-sided heart failure. They're going to have elevated systemic venous pressure with jugular distension. Their liver is going to be engorged, and they're going to have dependent edema. Now, externally, they're going to show fatigue and dyspnea. So, diagnostic, people with acute are going to have elevated white cell counts and usually have a fever. Therefore, blood cultures and sensitivities are going to be analyzed in the lab. The echocardiogram will usually show a STT spiking with the onset of the inflammation, which returns to baseline with treatment. Now, AFib is also common with these patients. Like I said, echoes are going to be used to determine if there's a pericardial effusion. And in chronic constructive pericarditis, thickening of the pericardium is seen on an echo and also on a CT scan. So complications, you're going to monitor all patients for pericardial effusion, which occurs when the space becomes between the parietal and visceral levels of the pericardium is filled with fluid. And this puts them at risk for cardiac tamponade, which is excess of fluid in the pericardial cavity. Interventions, the focus is going to be on collaborative care to relieve the pain and treat the cause of the pericarditis. Now, the healthcare provider is usually going to prescribe NSAIDs for the pain. Now, patients that don't obtain pain relief and don't have bacterial pericarditis can also be given corticosteroid therapy. You're also going to nursing care. You're going to assist the patient to that position that usually helps them. So sitting upright and leaning forward. If the pain isn't relieved within 24 to 48 hours, you need to call the physician and let them know. Now, the various causes, you're going to treat the symptoms or the causes of pericarditis. For example, bacterial, going to get antibiotics and pericardial drainage. Um, the usual clinical course of acute pericarditis is usually 2 to 6 weeks, but episodes can reoccur. Now, with chronic pericarditis, it's usually caused by malignant disease, and it can be treated with radiation or chemotherapy, whereas uremic pericarditis is treated with hemodialysis. Um, the definitive treatment for chronic constructive pericarditis is surgical excision of the pericardium or pericardiectomy. Now, they also may do a pericardiocentesis if the patient has a recurrence of tamponade or reoccurred infusions or adhesions for the pericardial from chronic pericarditis. They will eventually go in and do a pericardial window where they remove a portion of the pericardium to permit excess fluid to drain. In more severe cases, they'll remove the toughest encasing of the pericardium and do a pericardectomy if necessary. Now, nursing care, like we talked about, sitting them up. Also, after pericardiocentesis, you're going to closely monitor them for any kind of reoccurrence of tamponade. You need to be prepared to provide adequate fluid to increase their cardiac output and to prevent the patient and prepare the patient for emergency sternoctomy if the tamponade reoccurs. Now, the next thing we're going to talk about is myocarditis. Now, the patho on it might begin in one small area of the myocardium and then spread throughout the myocardium. The degree of the myocardial inflammation and necrosis determines the degree of interstitial collagen and lasting destruction. Now, the greater of the destruction, the greater the hemodynamic effect and resulting signs and symptoms. Now, the etiology is the myocarditis usually results from a viral infection such as the Coxsackie virus, HIV, or influenza A. It also can be bacterial. It could be caused by rickettsial, fungal, parasitic, metazoal, or protozoal, or spirohectal infection. It may also be immune related, occurring after acute systemic infections such as rheumatic fever. That can develop in patients receiving immunosuppressive therapy and in those with ineffective endocarditis. Also, people with Crohn's disease or systemic lupus erythemus. Now, myocarditis may result from an inflammatory reaction to toxins such as pharmacologic agents used in the treatment of other diseases like cancer. It can be caused also possibly by ethanol, radiation, those type of things. Clinical manifestations you're going to see for acute myocarditis, they're going to depend on what type of infection it is and the degree of the myocardial damage. Patients can be asymptomatic when an infection that resolves on its own. However, they can develop mild to moderate symptoms and seek medical attention. Most of the time, these symptoms are going to be fatigue, dyspnea, syncope, palpitations, occasional discomfort of the chest and upper abdomen. Now, the most common symptoms are going to be flu-like symptoms. Now, patients may also sustain sudden um, cardiac death or quickly develop severe congestive heart failure. So, diagnostic on these patients, they're going to do a CMR, which is cardiac mechanical resonance. They can also diagnose with a cardiac cath, and the white blood cell count and ESR may be elevated also. Interventions for these patients are going to be given specific treatment for the underlying cause if it's known, and be placed on bed rest to decrease cardiac workload. Now, if the heart failure or dysrhythmia develops, management is essentially the same for all causes of heart failure and dysrhythmias. With the exception of beta blockers are to be avoided because they decrease the strength of the ventricular contraction, having a negative inotropic effect. Now, NSAIDs should not be used for pain control. They have been shown to be ineffective in relieving inflammatory process in myocarditis and have been linked to worsening inflammation of the myocardium. They can also contribute to an increased mortality from increased virulence of the pathogen. Nursing care, you need to watch those two things. Remember, no NSAIDs, no beta blockers. The nurse also is going to assess for resolution of any kind of tachycardia, fever, and any other clinical manifestations. Cardiovascular assessment, you're going to focus on signs and symptoms of heart failure and dysrhythmias. Patients with dysrhythmias need continuous cardiac monitoring. And anti-embolism stockings and passive and active exercises should be used because embolization from venous thrombus can occur, especially in patients that are on bed rest. Now, these patients are going to be on strict bed rest. After recovery, physical activity will be increased slowly, and the patient is instructed to report any symptoms that occur with increasing activity, such as a rapid beating heart. In young patients with myocarditis, activities, especially athletics, are going to be limited for a 6-month period, or at least until the heart size and function have returned to normal. So it's a very serious disease, especially in the young people. Next, we'll talk about rheumatic carditis, and this is due to acute rheumatic fever. The rheumatic carditis is characterized by the formation of Ashkoff bodies, which are small nodules in the myocardium that are replaced by scar tissue. A diffuse cellular infiltrate also develops and may be responsible for the resulting heart failure. Now, the pericardium becomes thickened and covered with exudate, and a serosanguinous pleural effusion may develop. The most serious damage occurs in the endocardium with inflammation of the valve leaflets developing. Now, etiology, basically, like we said, rheumatic endocarditis is a response that develops after an upper respiratory tract infection with a group of A beta hemorrhagic streptococci. It occurs mostly in about half the patients with rheumatic fever. Now, clinical manifestations, and the reason I know a lot about this is my father ended up passing away from this. He had rheumatic fever during World War II, and it damaged his heart enough that when he was older, he ended up dying from it. Clinical manifestations, you're going to see cardiomegaly, which is in a large heart. These patients will have tachycardia. They'll also often have a pericardial friction rub and pericardial pain. Now, with the EKG, you're going to see a prolonged PR interval. These patients will also have indications of heart failure and evidence, usually of an existing streptococcal infection. Now, oftentimes these patients will develop a new murmur or change of an existing murmur. Now, for diagnostics, EKG and usually a positive strep test are what's needed to uh, diagnose this. Complications from this are going to be hemorrhagic and fibrous lesions that form in the inflamed surfaces of the valves, resulting in stenosis and regurgitation of the mitral and aortic valves. Now, interventions, usually penicillin is the antibiotic of choice for treatment. Erythromycin is also an alternative for penicillin sensitive patients. So remember penicillin and remember erythromycin. Now, once a diagnosis of rheumatic fever is made, antibiotic therapy is started immediately. So, nursing care, you want to teach the patient to continue with the antibiotic administration for the full 10 days to prevent reinfection. And you're also going to suggest ways to manage the fever, such as maintaining hydration, taking antipyretics, encourage the patient to get adequate rest. Okay, that's it for inflammatory heart disease, and we will go on to valvular heart disease next.